Anything. I have to say that.
Yeah, right.
Yes, absolutely.
Yeah. Yeah, it's all about the person.
You could probably start in the announcements if you want. So you'll just clip that on when you get up there. You can just, but you can just put it on right here.
Yeah, let's do it.
Might as well.
Actually, yeah, we got. There's not a feedback issue with these being right by each other, right? Okay, cool.
We're gonna be ready to retire next year.
Mm-hmm. Well, now you got it down. You don't want to.
Good morning, intrepid attendees. People of critical mass, welcome to 64 winter clinics. Please silence your phones. So a few housekeeping things. First, you need to log in digitally to Southwest AHEC. Here's the paper that explains it. If you have problems after the session, please see the folks outside of the table and they will help you. Also, please do sign in at the table as well in case we have technical issues that you will be counted. For folks who are online, please change your name in the participant list so you will be counted. Also, if you leave early, please sign out. And at the end of each session, stay present for the drawing after each lecture. Bathrooms, there's one outside the door, the rest are upstairs, down the ramp, in the hotel, and halfway down the hall. For Wi-Fi access, check the back of your badge, and also it will give you instructions on how to download the slides. And as we all know, if you don't feel well, please mask, stay in your room, etc. So I'd like to introduce Dr. Eric Scholten from St. Luke's Health System. He did play college basketball for St. Olaf's, and then he moved to San Diego and Minneapolis. He did his internal medicine training in Baltimore and fellowships in pulmonary and sleep medicine. Was it at a conference? He met some Boise.
No, on a chairlift, ski lift. That's how I know it. Yeah, right.
He met some Boise pulmonologists and moved to Treasure Valley. He practices pulmonary, critical care, and sleep medicine at St. Luke's and promotes COVID vaccines. He also has young kids that he is introducing into, and he's a regular attendee of the winter clinics. Welcome, Dr. Scholten.
Yeah, thank you. Okay. You guys hear me okay in the back? Is this audio's working okay back there? Hear me okay? Yeah? All right, excellent. Well, thank you for the nice introduction and thank you for having me. I love this conference, always fun to come and talk about it. I thought we'd just kind of do like a potpourri tour of cool stuff that I think is cool in the last 5 years. So there won't be any PFT minutia. I don't find that particularly interesting. We'll try to find interesting topics, at least that might be relevant to primary care practice. And we were just talking at breakfast, and I wanted to say kind of thank you to the community because seeing the growth in Ada County and the patients that kind of show up at your doorstep super sick from their multiple specialty care, I'm always impressed with how well the primary care community picks up these super complicated and sick people that are moving to our rapidly growing area. So in terms of disclosures, the basketball was Division III, so it wasn't super serious, number one. And number two, this was an old trial that's no longer active, and we're not going to discuss the PACER today. So that is in there. I just put this in there in case you have questions or patient stuff. You want to email me, we can get in touch right there. And in terms of background training, so I showed up in the Treasure Valley right kind of before the pandemic. So okay. And we'll just kind of go through these. This is the general list of topics. Let's just start. So, I think if we think about pulmonary, I often get frustrated because I feel like prednisone, Lasix, like Haldol in the ICU have been around forever. So there's not been as many advances as in like the oncology space. But one area that I'm sure we're all aware of is eosinophilic asthma. We've had a ton of new developments come out. So I thought it'd be worth reviewing just kind of the basic efficacy data for each of these agents and then the cost. And often which of these we can use is dictated somewhat by insurance. Typically insurance will have one of these agents approved for eosinophilic asthma, but I do kind of have my favorite, and I don't take any money from any of these companies. But so the one I've never used is the resolizumab because it requires an infusion center. It's an IV. You have to have an IV or a port every time. So I haven't used that. There may be reasons why you would want to. But if you look at kind of the second column here, that's the rate of reduction of severe exacerbations for each of these agents. And then for patients who are on chronic prednisone, the next column over shows which of the agents, what percentage reduction in daily prednisone doses achieved with the agents. So based on this data, I kind of favor Dupixent. That's what I generally use. I also tend to use Fasenra, which is benralizumab, because it can be dosed every 2 months. So those are kind of the advantages, I think. Pretty impressive reductions. And remember, I don't want to trip over this. Remember, with these, you have to have the biomarker needed for approval through insurance is an elevated peripheral blood eosinophil count. The research studies used the fraction of exhaled nitric oxide, but that's less available clinically, including in our clinic. We don't have that, which is a little suboptimal. But so you need peripheral eosinophilia to get this approved. They're all subcutaneous biologic injections. Several of them can be done at home, as long as I usually try to do maybe the first one in clinic or the first couple in clinic and then have them doing it at home. And these can really be game changers for people who are eosinophilic and allergic. They're all expensive. This is the wholesale cost, not the negotiated cost from the insurance company. You can see the pricing, so expensive. Xolair, omalizumab is one of the older ones, a little cheaper. So what do we do when they're not neutrophilic? I'm trying to think of there's the new drug we're going to talk about, but for people who don't have that eosinophil signal in their asthma and are neutrophilic, things I think about that I've seen really move the needle. A big one is hiatal hernias. I've had several patients with refractory. They're coming in all the time. They've got this big hernia. Their BMI is 40. We either often do a combo gastric bypass and fundoplication and repair of the hernia, and that really can improve some of these neutrophilic people because, you think about a heavy person with hiatal hernia laying at night, they're chronically microaspirating in their lungs, inflaming it, really setting off all the evil humors and whatnot. So sometimes mechanically fixing any reflux is a big thing that can help, and bariatric surgery is also helpful. And then exciting, in 2021, this trial was published with the brand name Tezspire tezepelumab, and you can see this number. This is a severe exacerbation graph, and the relative rate for people who are eosinophilic was 0.5, so a half, 50% reduction in severe exacerbations for eosinophilic. But a 0.6 rate ratio or 40%-ish reduction for people who were neutrophilic, which is great because none of these other drugs that we looked at on that first couple slide had efficacy for patients without that elevated eosinophil count. So this is a real exciting development for the space because prednisone likewise is generally not as effective for patients who are neutrophilic. So these are some of the toughest cases that are always in the hospital, always on 40 of prednisone. I've had a few do well with this. Thus far, it's expensive, hard to get through insurance, but this is a great new addition to the treatment armamentarium for patients with non-eosinophilic asthma. So just one to be aware of. And I think there's a booth up there I saw talking about that. This was kind of hot when I was like leaving residency, like 2015, 2014, bronchial thermoplasty. This is a thing. We do not do it locally here. I think the guys at the interventional pulmonologist at Utah may still offer it. And it's an interesting idea. So the idea here was put a bronchoscope in, go down to the subsegmental airways, the airways between 3 and 10 millimeters. You've probably seen a bronchoscope at some time. That's typically like 5 millimeters, the diameter of a bronchoscope, 5, 8, depending on how big they are. So you go out to the, not super peripheral, but kind of that in-between zone, and you apply radiofrequency energy to burn the inner part, the muscular part of the airways, and prevent it from spasming is the idea. The trials were kind of criticized because they excluded a bunch of sick people. They didn't actually show any improvement in flows on the PFTs, though the exacerbation rate did get better. Then there was a bunch of other conflicting trials after that, and the bottom line is it's a expensive, procedure that takes 3 times, but can have durable improvement in symptom control. It's very challenging to get through insurance, and all of the current respiratory guidelines say this should be done in a trial. So, right now it's kind of, I don't think, ready or widely available in the community. When you look at those costs, though, for those biologic drugs, if this could ever work, it's an expensive one-time intervention, but it, in theory, would provide durable control. Of course, we need data to show that. So I don't think this is like gone for sure, but my sense is the level of interest in this technology has kind of faded as new biologics come on. So it may be something that you see in the future. It may kind of be relegated to academic stuff. Interestingly, you may think, or at least I remember learning about this, that if you burn that airway and damage the airway, what happens to people who chronically aspirate? They get bronchiectasis, right? The airways scar and dilate out, and we do see that on CT scans in about 7% of patients in some series. So obviously, before we posit that, long term, this is like the panacea, we'd want to make sure that we're not hurting people in the long run with more bronchiectasis, et cetera. So interesting idea, I think. Other kind of tricks I use sometimes, and I'm sure you guys are aware, but just to review, theophylline can sometimes be really helpful. It's tough to dose. You got to check the levels and interacts frequently. I've had a few patients where they get on, a non-selective beta blocker that can worsen the asthma. Sometimes people really like Singulair but have neuropsychiatric symptoms. You can switch to Accolade. I've done that once or twice. It doesn't have the black box, but there are some reports of neuropsychiatric events. Of course, for Montelukast or Singulair, there's a black box warning for worsen of depressive symptoms or suicidal thoughts. So I generally don't use Singulair or Montelukast if someone has really significant depression history. That said, I don't think I've ever actually noticed a case where someone told me it worsened. I'm sure with the collective experience in this room, someone has had that happen, but just as a aside, that could be there. And I haven't used the competitor to Accolade ever, but just some side effects. So inhaler cost is a big issue, as I'm sure we're all aware. There is a new development here with a generic version of Symbicort that's coming out, or is out actually now. A patient told me about this. I didn't know that. I don't yet have the pricing for that. I couldn't find a wholesale price online. All these prices are wholesale 30-day costs. As you probably are aware, Advair now has a generic Wixela, quite a bit cheaper, easier. Most insurance plans are covering that, so that's something we tend to use a lot. And I'm really excited about a generic version of Symbicort becoming available, because as you'll see with the new GINA asthma treatment guidelines, they prefer agents that contain formoterol as the beta agonist, and for now that's just been Symbicort. So this is kind of the other big, I think, theme if we think about the last 5 years of asthma: biologics, neutrophilic biologics, and then as needed versus continuous maintenance dosing. So when I learned asthma in med school, it was kind of that conventional ladder, right? You start with the SABA, then you go up to the low dose, then the medium dose, and you just go up and down that ladder with a fixed daily dose every day to determine how much drug they should take. It probably what was happening, I'd think, is patients would be feeling fine, stop taking it, then they'd feel worse and start taking it again, and kind of doing a as needed anyway. At least I find lots of patients do that. So in the last 5 years, there's been some trials looking at this explicitly, a strategy of not taking a maintenance ICS at variable dose every day, but titrating it to your symptoms, within a wide range. And so let's look at some of that data. So this is from 2018. I think there's like 4 randomized trials, and I kind of pulled the take-home graphs from them. So this is a graph looking at moderate or severe exacerbations of asthma in, I think, a mild cohort of asthmatic patients. Same graph, just blown up here. And you can see the two superimposed lines are the budesonide formoterol as needed versus ICS maintenance every day. So titrating as needed versus maintenance. And then the other one here is the short-acting beta agonist alone. So you can see both of the treatments, both of the ICS containing arms in this population had better control in terms of preventing severe exacerbations. And I think the reduction in steroid dose by using it as needed was 40 or 50%. So they were able to achieve the same reduction in severe asthmatic control with about a 40 to 50% less exposure to the inhaled corticosteroids. So that was kind of cool. They looked at a score of symptom control, and this one actually favored the maintenance ICS in this trial. This is not consistent across all the trials, but there was about a 10 percentage points improvement in asthma score control. That was not driven by exacerbations. If you look at the components of the score, it was just driven by self-reported, how much does your asthma bother you? Important metric for sure, but not like hospitalizations or prednisone courses, et cetera. So something to think about as we use it. Then this is another trial, 2019, similar findings. Time to first exacerbation. So this is like a survival curve where the event is first exacerbation. The lowest line or the worst line, right? The black line here is the albuterol only. Maintenance versus as needed. Budesonide formoterol were very similar. Again, reduction in total inhaled corticosteroid dose. I think this is kind of showing the same thing. Exacerbation rate per year here, significant reductions, no difference between as needed and control, and number of severe exacerbations. I can't remember the time frame for that. This was a mild cohort, so probably over multiple years, since there's probably not 20 severe exacerbations. That's probably for the whole population. In any event, an actual improvement in the as needed cohort. And when I use this, we'll get to what I do, but I tell people they can range it from the whole dose range of the drug. So if we have like low strength Wixela or Advair or Symbicort, I tell them you can take whatever the math is, 4 or 6 puffs twice a day if it's particularly bad, to get up to that stronger dose as their symptoms vary. We'll talk about how I titrate it and coach it. So these trials, and there's a couple others I didn't include that show similar findings, generally equivalent control with less inhaled steroid and better control than the short-acting agent alone, led to a rewriting of the asthma guidelines, which I won't read to you, but I guess the bottom is kind of hidden. But the take-home at the bottom here is for people with mild asthma, they recommend as needed ICS or formoterol, which again typically was Symbicort. Maybe another one. I might be blanking on that, but as needed steroid-containing regimen plus a beta agonist. And they favored this formoterol because of the long-acting beta agonist, it has one of the quicker onsets. So it has features like a short-acting agent, but it has a longer duration of action. So you take it when you need relief, and you get benefit in terms of the beta agonism and opening of the airways quickly. So they recommend that, or just maintenance ICS is hidden. That's under the little logo here on the screen. But keep an eye on my time here. So what do I do? The Treasure Valley air quality is so variable. I have the little AQI on my watch, and I can tell how many calls I'm going to get based on the the air quality, how much prednisone we're going to have. Yeah, thanks, Steve. So I like this. I lean into this. I tell them, go from the lowest dose, if they're, depending on how bad they are, if they're like a bad asthmatic with an eosinophilic signal and we're not doing biologics, we'll start at a medium or high dose. But for most kind of mild, it's bad when the sage comes out, it's bad when the smoke's bad. I put them on, maybe a higher end of low and just have them titrate. I tell them to titrate every 3 or 4 days when it's a bad period, because the steroid effect does build up. It's not like in just one day, like the tone or the inflammation in your airways kind of reflects the previous week's inhaled steroid. It's not like a on-off drug. So I tell them kind of, just like I use the analogy of driving a boat. You don't want to like turn left, then turn right, then turn, kind of make gradual movements with the inhaler dose. But people generally figured out and generally do okay, especially in this mild kind of population, and especially with our air being so variable. So I think it's a great strategy. It's recommended by the guidelines. The challenge is getting the formoterol, right? Often insurance won't cover Symbicort. They'll only cover whatever, whatever drug it is. So, you got to kind of use your judgment. Sometimes I add they usually have albuterol anyway. So if it's not okay, but I haven't had too many tell me like they hate this and want to go back, and the ones that do are pretty severe. And then we're going down the biologic route anyway. So just kind of, I think that was the most of the points there. Oh, the other thing is, I found someone taught me, one of my pulmonologists, like keep your inhaled corticosteroid by your toothbrush, right? Like just make it part of your oral hygiene. So I tell patients, use it, brush your teeth, gargle, just keep it there. Even if you're self-titrating, usually they'll have several inhalers. The general dose is going to be 1 or twice tight a day. They might use it throughout the day, but keeping it there really helps avoid the thrush and the laryngitis. So. So sticking kind of with airways, but moving over to COPD. If we think about interventions that can reduce mortality, kind of the ones we know, smoking cessation, long-term oxygen, those are long-term. Remember pulmonary rehab, I'm probably guilty of not referring as much as I should for this, but if someone's had a exacerbation, great time to work on stopping smoking and great time to get them into pulmonary rehab, reduction in mortality in several trials with this, which is a big signal. And, I think that's probably driven just by, conditioning, right? Like with the lungs and the cardiovascular system both benefit from regular sustained workload in a controlled environment. And so make sure we're doing pulmonary rehab. You may have seen in papers, there's a lot of data for non-invasive for hypercapnic COPD. So putting someone on ventilatory assist to counteract the chronic hypoventilation and chronic hypercarbia. That's tough to do here because these trials that achieved this were done in Europe where there was very few DME restrictions, or maybe it's just in the trial they could do whatever they wanted with inhalers. But they very aggressively titrated these with like controlled, not just spontaneous bilevel, but bilevel with a backup rate, and really dramatically improved the reduction in PCO2. It's generally hard to get that here. You can go all the way to a trilogy with our insurance quirks, but so that is an option. It's not as easy as the trials make it sound to get a hypercapnic COPD patient on a fancy bilevel ventilator. And a new thing in the last 5 years has been there's several trials looking at triple inhaler therapy, meaning ICS, LABA, LAMA. Does that improve mortality? There's been lots of meta-analyses and discussions, and it probably does with a very high number needed to treat. So for super severe people, I generally am going to have them on 3 triple drug therapy, brand name Trilogy or Breztri. Number needed to treat against of 350. But those are some trials, the Torch and Ethos that came out, and that's basically, I think, kind of the take home, at least the way I interpret it. So. To review kind of the lung cancer screening guidelines, Preventative Service Task Force B recommendation, need 20 pack years within the last 15 years of smoking. So if you had a crazy history but are 30 years out, you don't qualify. They broadened the age range recently for this, I think in the last several years, so 50 to 80. And then the big thing is, of course, if someone's got widespread metastatic melanoma, probably not, we don't need to screen because the amount of time we're going to save. That said, even very frail COPD, stereotactic radios works very well, generally well tolerated. We send a lot of really sick people for that. Is that, you can debate the cost effectiveness of it, but even someone who's not going to be a candidate for a lobectomy or a thoracic surgery, there's really solid, 5-year control rate with especially for early stage with stereotactic radiosurgery. So don't necessarily exclude that just because they're super ill. I think there's been some interesting stuff that just came out, like using machine learning to look at these, because we've got all these huge cohorts of CT scans, and do they get cancer or not? And they fed these into these new massive data processing machine learning algorithms, and there's a lot of predictive power even before they have a nodule, and looking at just something in the signal that the brain has figured out, which is kind of scary. But so that you can do subgroups from the first scan, even if they don't have a nodule, and discriminate between someone who's got a number needed to screen of 120 and greater than 5,000. So I think in the future, there'll probably be algorithms that help us sort after they get their first scan. Or do we need to do annually? Can we do every 2 or 3 years? I think that will be coming. That's not yet ready for prime time, but Yeah, I guess that's what I wanted to say about that. So, okay, yeah, this is kind of a schizophrenic talk, so sorry to jump so quickly, but going to ILD, let's think about ILD. This is a super complex and an intimidating topic, and, there is certainly a broad complexity, but I think it's worth, I think a recent trial has helped kind of algorithmize or standardize the general approach to it. And I thought that's worth reviewing because sometimes this is a bit of a black box if you don't do a lot of pulmonary. So just to think about when someone comes and I see ILD on the chief complaint, like in my clinic visit, first, like probably equally important to the history is the high-res CT scan. That really gets us in the kind of different buckets of what the radiographic features are. History is critical. Exam, you want to hear the crackles, the clubbing, gives you a sense of how hypoxemic they've been, et cetera. But high-res CT and history is super helpful. And often that's enough, for someone in the right age demographics for idiopathic pulmonary fibrosis and the classic CT appearance, which is called UIP, which is from histologic, that's kind of an alphabet soup, but with a classic CT appearance, classic history, no other exposures, no features of rheumatic disease, you can make a diagnosis right there and start them on some of the drugs we're going to talk about. For most other people, either bronch or pathology with a surgical lung biopsy, surgical lung is always much, much more favored. You don't always get a ton of information from a bronchoscopy, but the key issue is often these people are very elderly. Like I just had a lady with scleroderma, an antiphospholipid, multiple strokes despite Coumadin. Like we're not going to do a surgical lung biopsy on that. So yeah, that's kind of the judgment. So then, all right, so we kind of have a general bucket of what they're in. How do we manage it? Just algorithmically. So everyone, we think about their vaccines, we check their oxygen at night, right? The first time as someone progresses through pulmonary fibrosis or progresses through emphysema, the first time they're going to need oxygen is at night, generally, right? They might desat a little bit when they exert, but I think of the risk of hypoxemia as a duration effect. So if I had to pick between them being hypoxemic for 8 hours a night versus 8 hours for 10 minutes when they're throughout the days they are walking or whatever, I would pick treating the night first because I think it's a duration effect. So anyway, do an overnight oximetry, make sure they are on the oxygen that they need to keep their levels okay. Inhalers, unless they've got asthma, longstanding, or COPD, or sometimes sarcoid, there's not usually a huge role for these inhalers, right? Because inhalers are targeting, I kind of tell people the analogy of like the grapes. You got a thing of grapes, the airways are the stem, the alveoli are the actual grape itself. Most of these diseases are alveolar or interstitial diseases between the alveolar and the vasculature, and inhaled meds just kind of deposit on the airways, right? So it's not really a inhaler disease. And so lots of education about, I take my albuterol, but I'm still winded, those kind of things is helpful. So that's for everyone. And then you've got the ILD patient. How are you going to treat them? Well, do they have an exposure or not that's driving it? So I print out the National Jewish Lung Exposure Questionnaire and we go through it. And I just print it out checklist style because there's a zillion things and you forget to ask something. I think about that reflux again. If it's a basilar process, right? We talked about the overweight person with the terrible scan. Sometimes they'll get lots of bronchiectasis or scarring down in the base. So address aspiration, gastric acid, antigens, pneumotoxic drugs. Address the exposure. And then really, are we going to immune suppress them or not? That's kind of do they have some overlap syndrome? Do they have rheumatoid? Do they have scleroderma? So you send some serologies, and I tell people I'm a very amateur rheumatologist, but you do like a good rheumatic review of systems and look for any evidence of autoimmune or rheumatic disease. And then the final thing here, I guess, thank you, yes. This is kind of what the whole point of all this long digression is, are they displaying progressive fibrosis on their imaging or on their PFTs? Are they rapidly losing lung function faster than normal? If they are, we have good data that antifibrotic drugs, specifically nintedanib, can help. So let's get to that.
Just tap on the screen.
Tap on the screen there, let's see. Cool. So nintedanib, brand named Ofev, was a drug that was in development for cancer. It's a tyrosine kinase, one of those cell signaling molecule inhibitors, inhibits multiple growth factors. And then I can't remember if it was like in animals or what, but they saw that it had some signal for efficacy in fibrosis. This led to trials in fibrotic lung disease. You still sometimes see it used for adenocarcinoma of the lung. There were several trials in the IPF population that showed benefit. Same thing with pirfenidone or Esbriet. So that's kind of older, like 2014, 2015-ish. And then there's this new indication where they took kind of all comers with ILD who are progressing and put them on it to see what happened. That's what we're gonna review in a second. Main thing to know about this drug and pirfenidone is gastrointestinal. I think in the trials, I think I have it in the slide, there's like 40% stop the drug. I find it in practice more like 50 or 60. It generally makes people feel terrible, nauseous, lots of diarrhea. You can manage it somewhat, but no one is excited generally to be on these drugs. But I'm frank with patients. These diseases have survivals akin to cancer, and this is chemotherapy. I mean, it's kind of the same paradigm. So, especially if they're young, we generally try it. And I have had some patients who do just great with it and they aren't even bothered by it. So it's usually worth a trial is the bottom line. So let's talk about the data. So as I said earlier, 2014, 2015, we had these trials for clear-cut IPF, improved PFT decline. So then in 2019, the company funded a trial where they looked at various causes of ILD who are progressing. So some autoimmune, some not autoimmune, some exposure, some, I love these names, like where is it? Other autoimmune ILDs, idiopathic nonspecific interstitial pneumonia, distinguished from unclassifiable idiopathic interstitial pneumonia. So, fibrosis and inflammation in the lungs, pretty broad cohort though. The point of this slide is some are, again, autoimmune, 25%, some are exposure, hypersensitivity, some are, we don't know, in fancy English, and some are other, whatever that is, so. But the great thing is so look at this graph. So the outcome in all these trials is not generally mortality, it's decline in FVC. Average FVC per person usually falls 40 cc's per year, rule of thumb. So in bad IPF, you're gonna be losing 200, 300, 400 FVC per year. So up to 10x the native decline in lung function that we all have. So in this trial, this is a year, 52 weeks at the end. If we look at the patients of that distribution I showed you just a second ago, people who go on the drug, this is an absolute value, so not a percentage, so ml, so 50% reduction, or I'm sorry, 50 cc reduction in FVC at 1 year for patients on the drug. Placebo, the native decline rate was between 150 and 200, so 4 or 5x background rate of lung decline. So definitely a sick population. They broke it into the UIP is code for IPF. Like these are people we think who have IPF, and we already know IPF works with this drug. So it wouldn't be valid to expand the indication for this drug if we just repeated an IPF trial. That's why they broke this up to people who don't have IPF and people who do, or at least the overall population. So this was a really, I think, practice changing trial. What I take from this is just to say diarrhea is bad. What I take from this is I monitor that FVC more frequently than I used to, maybe every 4 to 6 months. I usually trend to CT every year or two to look for that progression if we haven't already tried it. And then when and if they progress, we try it, because once you lose that lung that turns into fibrosis, you're not getting that back without a transplant. And so, and I think we're probably all aware, the median lung transplant survival is 5 years. There's a 20% mortality in the first year. So, lung transplant is not a great thing. It's better than death for a young person, but it's not a kidney or a heart or a liver. Like those all do much better. Side digression, but this is, I think, an interesting point to understand that. If you think about transplant, the kidney, the heart, the liver, they're sequestered from the outside world, right? Your lung, if you have a transplant, you're constantly balancing the risk of rejection by over-immune suppressing them with infection, right? So you can never get that balance right. So they're either always rejecting because you're running them too light, or they're always getting infected because you're running them too deep. And so I think that's why lung, as opposed to most of the other organs we transplant, does so poorly. But sorry, kind of a tangent. But of course, and so, I do the intense monitoring up front until we decide if we're going to start the drug or not, because once you lose that lung, you're not getting it back. Yeah, and I haven't found much success with re-challenging either. So usually we try it, we try the Imodium, we see if we can get them through it, and if we can't, then we stop the drugs. Sometimes people do better with one or the other, nintedanib or pirfenidone. be tough to get through insurance, et cetera, but there's basically 2 antifibrotics. I'm not aware, I looked at this for the talk, that pirfenidone has the same data for progressive fibrotic lung disease, so it'd be kind of off-label, but they have very similar efficacy in IPF. So, okay, so that's kind of ILD. So take home again, try the drug, monitor them. It's like cancer. It's a tough drug, serious disease, just to think about. So let's move to another great area. So it's I really like pulmonary vascular disease, but we're starting to see innovations trickle down from the neurospace. So this is just a rapid CT scan. Large vessel occlusion has just been revolutionized, and it's so awesome to see these people who'd have a devastating MCA stroke, and Pearl or Tony Bell gets in there and pulls it out, and then they just do great. And so, I'm sure we're all aware of the mechanical thrombectomy and how rapid CT perfusion imaging has really changed the game. I remember in 2010, you got to run them down for the hyperacute MRI, sit there for 40 minutes, wait for the perfusion scan to calculate the penumbra from the MRI, so then they can decide if they're going to go or give TPA or not. And now with this CT perfusion imaging, we get excellent quality, penumbra mismatch calculations to determine TPA yes, no, or usually mechanical thrombectomy yes, no, in real time, as quick as you can do a CT scan. So really great innovation, and has saved a lot of quality adjusted life years. So this is starting to come over to the PE space. So that's why, perfusion with the brain, perfusion in the chest. So you may remember VQ scans from training or looking at them, yourself. And so this is a nuclear medicine study where you do the counts of the emission, and you kind of get this grainy image where you're looking, at the front, or you're looking left anterior oblique, right anterior oblique, and you're trying to find perfusion defects. Typically, sometimes in an acute setting, more commonly to look for chronic clots and chronic malperfusion. The trouble is, let's say this is a left anterior oblique here. So this signal is the heart that's missing, right? Because the heart's in the left side of the chest. But, is it really there? Is there something else there? Or if there's a poor perfusion signal here, maybe there's a cyst in the lung. And so you try to do the ventilation component and match it, but it's just hard. And the new scanners are just, it's cool technology, really. So what the new scanners do is, with one load of contrast, they used 2, I'm not a radiologist, I'm sorry if anyone is, and I'm doing this poorly, but the first amount of energy just gives us the standard CT scan we see, and then they project a second beam that shows the perfusion of the iodine particle throughout the lung. So you have 2 data series. You have the red perfusion, good perfusion, bad perfusion. And then with that, you can generate 3D models of the lung. You can see, wow, this whole area in a vascular distribution is not perfused, and there's no structural abnormality to account for it, right? So if someone has a big cyst or a big bleb, you don't expect good perfusion. It can be somewhat challenging to see that on a VQ scan. Not at all challenging when you have a CT scan that you can window in lung windows to see the parenchyma and then see the underlying perfusion. So really cool technology, and I think going to be very helpful in the chronic thromboembolic space, which is more of a specialized center thing, but just cool images, and you can just see, it's just a picture's worth 1,000 words, I think. The other thing that's new in the last, I'd say 5 years, is MR, pulmonary angiography. So the scanners have gotten better, the gating has gotten better, that we can get pretty high resolution up to the segmental arteries, which is generally the clinically significant clots, for people who have a severe contrast allergy, or perhaps kidney disease, though the kidney iodine contrast risk is, I think, kind of fading in importance and severity. And so this is an MR, axial view, large clot. So that's a cool option that is becoming available. It just takes longer. So if you can use the traditional perfusion scan, it's a better image. But for people who have a super severe allergy, we've used this a few times, can be helpful. And so with all this great perfusion imaging, are we going to follow the neuro paradigm and start pulling out more clot? That's the question. And I think the jury's still out. If we're going to do it, it's going to be probably in this intermediate category of severity. So remember, we kind of classify acute PE into 3 categories: massive, meaning you're dying, hypotension, you're either going to get TPA, you're going to go on VA ECMO, or, Andy Forbes or someone's going to pull out the clot surgically. Intermediate is always this gray zone where they have a high risk of death the first 48 hours from the next clot, right? They tolerate the first clot, but the next one down the leg is going to go, and then the RV is just on the brink. Low risk is straightforward. Again, back like 2012, 2015, ECOS was super hot. This was this thing you put in through the either the groin or the neck. It's an ultrasound catheter, and it would give a low dose of lytics over 48 hours. Never really showed much in terms of hard endpoints. Like, the main outcome they used was the RV getting better quickly, but when they looked at harder outcomes like prevention of death, prevention of post-PE syndrome, prevention of CTEPH, nothing really paired out. So that's kind of fallen out. Plus, it's very resource intensive because they're generally in an ICU for 2 days, getting this expensive device, getting TPA. So that was kind of this was kind of what we used for high risk intermediate before, or sometimes a massive where they have a widespread metastatic disease in the brain. You can't give them systemic TPA or something like that, or just a particularly older person, borderline. So Tyler Harris and the excellent, I love our interventional radiologists. It's just a fantastic group, but they're really hot on these new catheters. They've been able to shrink the technology so you can get a lot of clot outs quickly. And same story as ECOS though. This is early. I'd say we're 1 or 2 years into this, at least in this center. I'm sure academic places have been using these longer. We have good data that it improves kind of surrogate markers. So PA pressure reductions, cardiac index improving when people have a swan in, troponin, profile. If you integrate the troponin curve, you kind of get an endpoint of myocardial damage, right? So trials pending, but I mean, what's cool, so here's the echo image, here's what they pull out in like 30 minutes, I mean, huge clot. This is like a surgical embolectomy photo from 10 years ago, and this is with a large catheter, but they'll do these on Lovenox. So if you call me and there's like an 80-year-old with a terrible looking scan, huge clot, proximal clot, it's acute, meaning they came in within a day. It's not like from 3 weeks ago. And their pressure's 95, but they fainted. It's definitely high intermediate, and it's an older person where I'm not eager to give them systemic TPA because of the bleeding risk. This is definitely an option if they're in our bigger centers, and we'll do this. So we probably do two a week, maybe 1 a week. I don't know. We meaning Tyler, not me, but he gave me the photo though. But yeah, we've had a couple of these cases just do really well. So again, I'm not saying this is like standard, but I think in the appropriate population, and I think there's lots of trials coming. So just like it took a long time for mechanical thrombectomy for neuro to make its way to mainstream and widely accepted, I think we might see this here. The big other question is getting this out going to help avoid chronothromboembolic or post-PE syndrome or any of those kind of more lingering conditions that complicate 1 to 3% of these cases. And on this, sorry. But yeah, cool image, cool technology, a space to watch. Okay, so continuing with our rapid switching here. 20 minutes. So I thought, thinking about this audience, what would be good to review? I think people are probably pretty familiar and comfortable with CPAP and bilevel for routine upper airway obstruction because someone's a little heavy. But you may not be as familiar with AVAPs, IVAPs, and ASV. So I thought we'd kind of just do why do we use these and what do they mean? Just so you have some background knowledge. And I'm sorry if this is duplicative or too simple. So if we look at a sleep study, this is a home sleep study. You can really get almost all of the information on a sleep study from the hypnogram, which is just the graphical display of the night's data. So the time got a little cut out on my snip here, but this is 11 p.m., 2 a.m., 6 a.m., all the way at the end. And each of these little ticks is a respiratory event, a hypopnea in this case. And our final graph, of course, is the oxygen. So if we just zoom in kind of on this section, we see that when the upper airway is open, meaning no respiratory events, the oxygen level's normal, right? 94. As we sleep, we all generally hypoventilate slightly. Our muscle tone relaxes. If I'm 98 right now, I'll go down to 94 when I'm sleeping. There's a normal drop in saturation mediated by mild hypoventilation. But basically, this person, assuming they're sleeping here, they have normal oxygen. Their oxygen is going to drop when they have an event. This dip here is an artifact. They rolled over, so that's not a real respiratory event. So this is a straightforward routine sleep apnea hypnogram. They're hypoxemic when they're having respiratory events. Otherwise, they're not hypoxemic. You open the upper airway, it's going to be fine, right? Their oxygen will be normal. A less routine hypnogram would be something like this. So the only thing that's different about this graph compared to, two things. Same thing, time on this axis. This is in the sleep lab, so we actually can see what stage of sleep they're in. So gray is wake, N1, N2, N3, and then REM sleep is the red graph. And then if we look at this person's, oh, sorry, the other new thing is we have a transcutaneous carbon dioxide monitor on this person, so we can see what their blood CO2 is in real time, which is kind of cool. Takes a little bit to equilibrate, but you can see their PCO2 is not normal. You know, they're up 50, 51, something like that. But if we zoom in on that first section, analogous to our previous case, we see that this person, despite not having any respiratory events, is satting 82, 84, you know, so there's something wrong with their ventilation independent of the patency of the upper airway. And so this is where we start to get into the IVAPS and AVAPS mode. I guess the other thing so we note the resting hypoxemia, even, you know, they're definitely asleep, they're still 88. In REM, I mean, just look. So remember, in REM, our brain is super active. It's an equivalent to being awake. You know, like if I just looked at a functional MRI of someone who's awake and someone who's in REM, tough to distinguish. Your brain is super active, but there's a switch in the base of the brain that prevents your muscles from activating, right? So in REM, we are all paralyzed. Our muscles are flaccid and relaxed. And so people with neuromuscular disease will tank their saturations in REM because they're just ventilating and just hanging on when they're awake due to their muscular impairment. And then you take away the muscle tone in REM and they generally tank their oxygen. So that's a kind of a clue that this person may have a muscular problem. But this patient actually, the issue was marked kyphosis and some paralysis in the lower thing. So, but the bottom, you don't need the specifics are less relevant. But any of these kind of syndromes will give you this hypnogram where they're not ventilating enough, and it's not just an upper airway problem. It's one of these problems. So abnormal load on the lungs. So someone is 500 pounds. You know, it's harder to take a breath when you're 500 pounds. Over time, your brain gets lazy and that set point kind of migrates up and up and up, and your PCO2, instead of being set at 40, gets set at 55. Abnormal load on the lungs, building that up, that will give you this hypnogram. Abnormal lung resistance, so end-stage COPD, you know, your airways, same problem. Airways are super tight, you can't breathe well, you gradually breathe less and less, you gradually become hypercapnic. End-stage emphysema, if it's more just destruction of the lung, instead of breathing at our normal, you know, spot here, you take a big breath up and try to breathe up here, and it's hard to do. Hard to do, brain gets lazy, hypoventilate, PCO2 rises chronically. Weak musculature, ALS, myotonic dystrophy, muscular dystrophy. So all of these syndromes, if you kind of just any chronic hypoventilatory problem where that set point is going to give you this hypnogram. So how can we treat it? That's where these come in, AVAPS and IVAPS. These are like Pepsi, Coke, just brand names of the same things, but these are, and the manufacturers are there. I have my preferences, but whatever. They're basically the same thing. These are algorithmic, basically ventilatory support devices. So they do treat obstructive sleep apnea by putting the PEEP. So you put the PEEP wherever you want to keep so if someone's 500 pounds, they're going to need a PEEP of 12 or 15. Pick the shoe size, someone told me, which is not actually a terrible surrogate. You know, if it's someone much smaller, they're going to need a PEEP of 5, and then the algorithm is going to measure their ventilation and adjust the pressure support to ensure you get a level that you set. So it's a ventilatory assist device to combat all of those various conditions. So yeah, I'll just kind of leave it at that. You have to do an in-lab titration. They're expensive. Yeah, and then the titration, those is cool. You'll see that's what the end of that other sleep study was. We're getting on time. Yeah. I guess the point of this is, like, if I took Jess Eilert, who has a normal BMI here, and I gave her like 100 of sucks in her arm, and she's just sitting there, like, it's not hard to ventilate someone just with a mask if they have a normal BMI. You need like 7 or 10 of pressure. So bi-level of 15/5 for someone with a normal BMI will usually be able to move enough air to normalize all those parameters. So you don't, I think before I learned this, I thought it was like, oh, you have to have a super powerful ventilator and lots of things, but it's generally not. For a normal BMI and a normal rib cage, you can ventilate someone quite well with the BiPAP mask. Those of you who work in ICU see this, and we have someone with a terrible stroke who's DNI, we strap them on BiPAP. They can go a long time with minimal respiratory effort. The issue is secretion clearance and that, right, getting rid of your coughing and all that. But so the point is, these ventilators can generate plenty of pressure to ventilate most people, and most people we can restore normal ventilation. Now they have to tolerate the mask. That's a separate story, you know. But so you can see this person goes, this part of the sleep study, they're on the treatment. They're on BiPAP or AVAPS. I don't remember which it was, and they're still having some events. But in general, let's look at REM here versus native REM when they're off. So oxygen, tons better. Carbon dioxide, tons better, right? And so you can kind of normalize it. This wasn't the best example. There's somewhere it looks perfectly pretty, but this is just a good, I saw this while I was making the talk. I was reading this study, and so that made me think of it. So again, IVAPs, AVAPs help ventilatory problems, tough to get approved, but that's the point of them. Not always necessary too, though. Like, first line for obesity hypovent is just open the upper airway. If the air tube goes from this to this, you get more ventilation. And so plenty of patients with obesity hypoventilation, if you just treat their sleep apnea over time, their PCO2 will get better. The other kind of pearl I'd say about that is, that hypercapnic symptom is a very chronic disease. So I'm not going to repeat the blood gas next week. I'm going to repeat it in 3 months, assuming they're using the bilevel. You build up in your bicarbonate stores throughout your whole body. So it takes a long time to ventilate that down in the chronic hypercarbia. We're not talking about the COPD or the narcotic overdose, which is a quick hypercarbia, but for these chronic people, it changes slowly. So I think sometimes people trend it too quickly in my view, but. Okay, and so ASV, so moving from IVAPs, AVAPs to ASV. ASV is designed for a different condition. It was designed for Cheyne-Stokes and heart failure, and we'll talk about the data for that. So Cheyne-Stokes and heart failure, the ventilator control centers in the brain are out of sync with the pump. So normally when you change your breathing, your heart's working well, the carbon dioxide has a normal, 30-second lag time till it hits the brain, and the system's in sync. You get end-stage heart failure. It now takes 60 seconds instead of 30 seconds for that blood in your lungs to reach your brain. And so there's this phase delay and lag in ventilatory control. You overventilate, underventilate, overventilate, underventilate. So ASV was designed to fix this. What ASV does is it gives you a fixed PEEP during this phase with no pressure support. So it's not going to help you breathe at all. And then as you start to hypoventilate, it's going to breathe more. So it does the opposite of the native breathing pattern in an effort to smooth it out. And it sure works on a PSG. I mean, it will make this look perfect, that hypnogram, and it's really hard to not want to do that. But as you probably are aware, the SERVE heart failure trial, this is a graph of mortality in patients with Cheyne-Stokes respirations and central sleep apnea, and you'll notice that the treatment group did significantly worse in terms of mortality than the control group. So that's unclear why that is, but as of now, you're not supposed to use ASV if the EF is under 40%, which was the inclusion for this trial. This was the ResMed machine with a ResMed algorithm. Philips had a competitor, or still has a competitor, ASV machine with a, quote, different algorithm. They have been talking about this Advent heart failure trial, which is the replication of the SERVE trial, and it's still not out. I was looking at it for this talk. May have been canceled. So I'm wondering I'm not sure what's going on with that. So stay tuned. I think the jury's out. I would love to see the data for this because this is a very surprising result. The oxygen's perfect, the ventilation's perfect. There's no residual events, yet they die more. Not good. So I'd be very curious to see the result there. So I think we're running low on time, and I've talked about a lot of stuff. So let's just, I will do this. So Inspire, mass marketed. We've all heard of Inspire, I'm sure. This is a source of headaches for me. So the thing to know about Inspire can be great. I've had patients do great with it. If you look at the key take home from the trial, though, 929 patients were screened and enrolled. 126 got the device. There are tons of exclusions. You have to have the right BMI. You have to have the right severity of the sleep apnea. You have to have the right insurance that'll pay for it. You have to be willing to undergo a general procedure with a neck dissection and a thing here. You have to be willing to sleep with your tongue out. You have to have a pattern of tongue collapse. You can't have a certain threshold of central apnea. So by the time you get through all this, it can work, and it does work well for some people, but this is not, let's advertise to everyone who has a BMI of 50 on the radio that they should get an Inspire, which is what happens, and I get that the company wants to make money, but and it's a great innovation. But anyway, we get a lot of stuff. So I do ask you, do not send them to the surgeon directly, because the surgeon's not going to manage them afterwards. So if you want to manage them afterwards, totally fine, send them to the surgeon. Otherwise, send them to us. And another slide I have is how terrible our wait list is and how hard it is to see us. So I'm sorry about that. But this is, so yeah, send them to us in 6 months. But, it is a second line treatment. This is not an emergency. We should be thoughtful about this. It's an $80,000 implant separate from the cost. So just send them to us, please, would be my advice, unless you want to do it on your own. So we'll, I got a bunch of other stuff. Be skeptical of narcolepsy. There's a lot of meth abuse, that's the take home of that. That's because I did my sleep fellowship at a county hospital, though. So maybe I'm, yeah. So I'll put this slide up because it's talking about and apologizing for our challenges in getting patients in. And I know you guys are, as I said at the beginning, overwhelmed with complex people wanting 15 specialists immediately on their case. We do have a triage system, so we have to prioritize. So, tough cases like this, we can get in quickly. Routine COPD, routine asthma is going to be tough to get in. Boise Asthma Allergy does a great job. We have plenty of business. There's nothing wrong sending to them. They usually have a quicker wait time for eosinophilic, especially asthma. But if we have some case where you're not sure, you're worried about it, you want to talk to one of us, we are happy to do that. So best ways, have your MA call our clinic. They can get your number. The clinic doc will call you later that day. Or this is a very good option too, that is, this person has bandwidth. So it's never wrong to call the tele ICU. We cover like the McCall Hospital, a bunch of other places. We'll look at scans with the ER, figure out, do we need to do a biopsy? What do we need to do? So if you ever need to talk to a lung doctor to figure out what to do while we're waiting to get them into clinic, feel free to reach out via those two routes. Again, apologies for our dysfunction in clinic. There's the kiddos, and I'll stop for questions.
So raise your hand if you have a question, and I'll come running over with the mic and speak close to the mic. Any questions? Okay, way next side of the room. I don't feel like Vanna White over here. I don't know. Chariots of fire.
Eric, I have a question that kind of tricky one maybe, but
Sure.
The carbon footprint of healthcare, and I
Yeah.
saw the UK Health Service calculated that meter dose inhalers are 4% of their total healthcare system.
For sure.
Greenhouse gas emissions.
Yeah.
So I was wondering, for patients who are interested in this and they want to switch from meter dose inhalers to dry powder, do you have some tips on how that can be done?
No, I found it very stochastic. Like some patients tolerate that totally fine, switching, and some don't. I don't have like a predictor of who will do well with that or not. So just to clarify for everyone, so the ones that say HFA or hydrofluoroalkane, that is a very potent greenhouse gas. That's the propellant. I think we went to HFA, you correct me if I'm wrong, because before we were using the chemical that depleted the ozone as the propellant. So we solved the ozone problem. And now we've definitely created a warming problem with the propellant with basically all inhalers. The ones that are dry powder don't have that. And I think industry is hopefully starting to move away from HFA to that, but we're a long ways away. So I haven't found a trick except to try it if they ask about it. Or the other issue is honestly insurance, though. Sometimes insurance will only, there's not a DPI option sometimes. So definitely a big issue, right? Because the fires are worse because we're warming. So we're using more albuterol because we're warming the planet and fires, and it's this circular logic. So thank you for mentioning that. I don't have a great solution. We just had a meeting about this a couple of days ago. So good question.
Other questions online?
Could you comment a little bit on your change of inhaler recommendations for the milder asthma to intermittent use and chronic use, and whether there's a change in the association with pneumonia?
Yeah, I haven't, that would be I didn't see that as I was reading the paper. So you would posit, so inhaled corticosteroids increase risk of pneumonia, right? So you would suspect if we went to an as needed, we might see less of that. I didn't see that reported in the trials, though, and anecdotally, it's hard to say anything intelligent just because you see people so erratically. But I think it's a good idea. I think less drug is always a good idea. I think the thrush and hoarseness is okay, especially if we can achieve the same control. So if I had to guess, I would expect with a lower inhaled steroid dose, we would see less pneumonia. I did not see that reported out in the trials, probably because for a healthy, mild asthma population, pneumonia might be a rarer endpoint, you know what I mean? Rather, this is not the end stage COPD, always getting admitted population that they're studying. It's kind of the mild on step 2 or whatever of the old paradigm. So I don't know, but I think you're right on. It would probably lead to less. Is that what you were alluding to or no? Yeah. Yeah.
Association, because that's been a controversial state.
Yeah. For sure, yeah. I mean, this is like I feel like this is the nephrology versus cardiology in the diuretic discussion. It's like, no, give more, no, give less. Like I'm like, yeah, put them on a PPI, man. Don't, there's pretty good, the data I rely on from the lung transplant, like rejection rates definitely go up based on however you measure it. So there's been some studies where they put a pH probe in and they measure the amount of reflux in a 24-hour period and then correlate that with rate of decline of the allograft. So I think it does, but I agree the guidelines are kind of wishy-washy on it. But man, there's for sure people who they're telling you with their hiatal. I mean, it's a shade of gray, right? Someone who's labeled as GERD and only if they eat spicy pizza once a month has it. Are they going to benefit from like taking PPI every day? Probably not. Is the person who's waking up with the sour, just every severe stuff, their asthma does get a ton better when we either put them on a PPI or usually bariatric and fundiplicate. I send tons of people to bariatric surgeons because number one, they're not tolerating CPAP, or number two, that kind of paradigm on that one slide I was talking about. So I'm a big believer in that. It'll be curious to see if these new diabetes drugs that you guys probably know more about than I do, the GLP-1 ones, have a role in this kind of weight loss space too, which is so important and so challenging, as we all know. So good questions.
There was that episode of Vaping Associated.
Yeah.
A few years back.
Mhm.
About TV was right with the media. Is that still an issue?
Yeah, great question. So correct. So just to review, so kind of right before the pandemic, right? I think it was, or right around the start of it, we saw this outbreak of young people with so-called EVALI, electronic cigarette vaping associated lung injury. And, lots of controversy, lots of trials, or lots of case series. It does seem like vitamin E was being contaminated, specifically in people who were using custom or home brew, often like a marijuana derivative or some sort of custom thing where you could make it. Less so in the huge brand name, quote unquote mainstream products. But yeah, I think my understanding of the issue is primarily vitamin E contaminant, primarily in smaller market custom. Your friend makes a brew that you vape that then gets contaminated. So if I have people who are vaping, I tell them buy it from I don't know which is a quote good one, but I tell them like a major brand name at a store, not your buddy down the street. Don't mix it with other stuff. Really, we should not try to inhale anything in your lungs. If people want to use marijuana, I tell them use edibles. Like, why would you, if you're going to do it, don't put stuff in your lung. My bias. Yeah. So, yeah. Mm-hmm.
About the DOAX and pulmonary emboli, and
yeah,
do you stop it? Do you lower the dose?
Yeah.
Keep them on it forever?
Oh,
Kind of thing.
right. Great question. I could have done a lot. So always a hard decision. Sometimes easy, antiphospholipid or metastatic, whatever, they're going to be on it. But these intermediate ones, especially if it's big, there's a couple strategies I use. So there's a trial of apixaban 2.5 daily, so low dose, at least in the follow-up of the trial, no recurrent clots, no increased bleeding because it's such a low dose, so that's an option. I sometimes do a D-dimer guided strategy, so they're finishing the 6 months. I think they're intermediate to, I'm worried about it, I'm thinking about keeping them on it forever. There's a couple good papers where you check a D-dimer on anticoagulation, then you check it monthly for the first 6 months, and if it exceeds, there's a threshold, I think it's 600 or 700, you get a lot of predictive data. And if they stay low and are not having any rise in the D-dimer on monthly checks, you can stop it safely with no recurrence in these trials. So sometimes I use that strategy if they're on the fence. But we all see car versus bike. We all see we're in an active community, right? So like catastrophic intracranial is a real risk. So I usually just frank discussion. We're taking a risk either way. How nervous are you? I think the DOACs have helped because I think they're generally safer than Coumadin, et cetera. So I don't have a great answer, but sometimes D-dimer strategy, sometimes low dose apixaban, sometimes heme. If they're really nervous, get a second opinion. It's definitely worth a second opinion in this case because it's a gray area, I think. So good question. Okay, thanks guys. Appreciate your attention.